The short answer is I don't think that we know that from my study alone. We know that in the PICU that we underutilize professional interpretation, and we know that professional interpretation is linked with better outcomes. This study is the first study to look at what happens when we allow families to initiate interpreter use. The model at my hospital, and I think most other hospitals, has been that clinicians always initiate interpreter use. And I do think that leads to clinicians cutting corners and likely not using interpreters as much as we should. And then it also focuses all the interpreter use on clinician needs and not necessarily family needs. So the study looked at what happens when we allow more bi-directional communication with our non-English speaking families, and allow our non-English speaking families to initiate communication with us. In this study, I did not look at shared decision making or clinical outcomes. I just looked at the raw amount of interpreter use before we initiated family initiated interpretation, then after we started using family initiated interpretation. Yeah, I do think that's the what should be the next step in this research is looking at does increasing interpreter use actually lead to changes in outcomes. We know that our children from families who use a language other than English, they're more likely to have adverse events in the hospital, and their parents are less likely to feel comfortable speaking up about concerns or questions they have about their children's care. So my hope is that directly equipping families with interpreter technology will decrease barriers and allow families to feel more comfortable speaking up. And I hope that ultimately translates into fewer adverse events and decreased length of stay. But more work needs to be done to prove that. I think there are a few barriers to making this widespread. One, from a hospital and system standpoint, for this project to work, I needed there to be a video interpreter tablet in every room of a non-English speaking patient. So we had to increase the sheer number of video interpreter tablets available in our ICU. So we had to double the amount of tablets available. So there is some cost associated with this endeavor. And then we are billed by the amount of time that we use interpreters. So there is a cost associated to increasing interpretation. So I think both of those are potential barriers. I also think that family buy-in is really important here, and encouraging families to use this technology requires investment from the medical team to encourage families, and then requires families feeling comfortable with technology and having the literacy to read the instructions to actually use the iPad. I do think having interpreter technology available in every room permanently for the duration of a child's stay, I do think is really important. To have that video tablet available, I think does two things. It flags to clinicians that this family uses interpretation. So just a constant visual reminder in the room that this family needs to use a language other than English, I do think helps clinician behavior. And I also think taking the choice away from clinicians on whether or not to use interpreter technology is important. It should be automatic that we use interpreters with these families. And so I think giving families the ability to initiate interpretation, to take the choice away from clinicians, I do think is really important. And I do think widespread, just increasing our interpreter availability is also crucial. Both families and medical teams actually prefer in-person interpretation more than anything else. So I think increasing in-person interpreter availability, especially on off hours like weekends and nights when children are still critically ill in the ICU, I do think is very important. I do think there's a lot of work to be done to mitigate disparities for our non-English speaking families. A lot of research right now focuses on just disparities and describing disparities. And I think the next step for decreasing disparities in this population is start to work on interventional projects, like the one I have done, to try show ways that we can make ourselves better at taking care of this population. I also think that with AI technology, there's going to be a lot of opportunities to incorporate AI for real-time translation and interpretation for these families. So I think there's a lot more work to be done. I do think the field of disparities research needs to both describe the problem because you can't fix a problem if you don't know about it, but then also take that next step of incorporating implementation science and QI work to actually work to mitigate disparities.